هنشوف محمد هيقول لنا ايه. اتفضل يا محمد.
مش هشوف حاجة أنا كده في الكاميرا دي. هتنزلها تحت شحن أو أرفعها عشان مش شايف.
أول واحد قلته؟
لا، محمد دنيا ده. بس هو مش هو ده اللي عاوز بريزنتر فيور، قال لي هشغل بريزنتر فيور.
مش عايزاه؟
لا، في البريزنتر فيور، قال لي هشغل بريزنتر فيور اللي هو يبقى عندي النوتس
مش هو البريزنتر بتاعك؟
ايوه بس في بتاع، في النوتس بتطلع كده.
براي؟
اقول له في النوتس يبقى عندي بتاع كده، وهنا مختلف بتطلع هنا مختلف. قول له بس الاول عشان
شوف ابراهيم فين. ماشي. لا، في حاجه ثانيه.
طيب خلاص ماشي طيب خلاص اوكي. بس النور بس اللي هناك.
ماشي.
بسم الله الرحمن الرحيم. The title of my talk is the differential diagnosis of pediatric macrocephaly. These are the main references for my talk, starting with the outlines: macrocephaly versus megalencephaly, compartment approach in the differential diagnosis of pediatric macrocephaly, types and causes of megalencephaly, overgrowth syndrome, finally the roadmap to differential diagnosis of pediatric macrocephaly. Starting with the definitions: macrocephaly is a common clinical condition affecting about 5% of children, defined as abnormally large head with an occipitofrontal circumference greater than 2 standard deviation above the mean for age and sex, while megalencephaly is brain overgrowth more than 2 standard deviation above the mean in the absence of increased intracranial pressure. It is classified as developmental or metabolic. Both have underlying genetic causes. The developmental megalencephaly or metabolic megalencephaly. Developmental due to genetic mutation affecting the PI3K ACT mTOR signaling pathway, which is responsible for cellular overgrowth and proliferation, while metabolic megalencephaly is secondary to inborn error of metabolism. The compartment approach in the differential diagnosis of pediatric macrocephaly is divided into causes in extraaxial spaces, ventricles, brain parenchyma, and the skull. The extraaxial spaces may be due to benign enlargement of subarachnoid spaces or abusive head trauma, the ventricle or hydrocephalus, whether congenital, acquired, or increased CSF production, brain parenchyma or megalencephaly, developmental or metabolic, with skull macrocephaly may be due to skeletal dysplasias or thalassemias. A systematic approach, which include a thorough clinical history, physical examination, are crucial in the evaluation of a child with macrocephaly. The first and the most important step is exclusion of raised intracranial pressure. Starting with the benign enlargement of the subarachnoid spaces, it is the most common cause of macrocephaly in infant due to immaturity of arachnoid granulation with spontaneous resolution by 2 years of age. Here we can see enlargement of the subarachnoid spaces over the frontal convexity more than 10 millimeter, and subarachnoid vessels traversing the dilated subarachnoid spaces. There is an increased risk of developing subdural hematomas due to stretching of the bridging vein traversing the subarachnoid spaces. The main differential for this is the abusive head trauma. Here you can see bilateral subdural collection of near CSF density compressing the subarachnoid veins over the brain parenchyma. Second is hydrocephalus. It is disorder of CSF function and flow dynamics characterized by ventricular enlargement that present with macrocephaly when the onset is before 2 years of age. It's made due to congenital hydrocephalus as aqueductal stenosis, KRE2 malformation, then the Walker malformation. While acquired hydrocephalus, they may be extraventricular or communicating, post-infectious or post-hemorrhagic, or obstructed due to obstructing tumors, such as pineal region tumors or posterior fossa tumors. Third is increased CSF production due to choroid plexus tumors. Shifting to brain parenchyma or megalencephaly, which is divided into metabolic or developmental megalencephaly. The metabolic may be due to leukodystrophies, organic acidurias, lysosomal disorders, or Menkes disease, starting with the Canavan disease due to abnormal accumulation of the N-acetyl aspartate in the brain, CSF, plasma, and urine. This diffuse involvement of the white matter with involvement of subcortical U fibers, involvement of the salami and the globus bladi, sparing the butamina and the caudate, and the MRS shows characteristic sky-high choline peak. Alexander disease characterized by presence of frozen cell fibers in the astrocyte, white matter involvement with frontal predominance with posterior progression, involvement of the external extreme capsules, periventricular enhancement, caps of periventricular enhancement around the frontal horn, وفي signal abnormalities in the medulla. Third is megalencephalic leukoencephalopathy with subcortical cyst or Van der Naab disease. There is diffuse involvement of the white matter with involvement of the U fibers, with sparing of the deep gray matter nuclei and the internal capsule, with a characteristic subcortical frontal or subcortical temporal or frontal cysts. Fourth is vanishing white matter disease. And affected individuals typically have normal early development followed by progressive neurological deterioration. White matter involvement with the involvement of the deep and periventricular white matter sparing the subcortical U fibers. Flare showed periventricular cystic degeneration. And there is a characteristic radial stripe radiating from the ventricular surface and sparing of the outer rim of the corpus callosum. Shifting to organic aciduras, L2 hydroxyglutaric aciduras, due to accumulation of L2 hydroxyglutaric acid in CSF and urine. There is involvement of the subcortical U fibers and typical sparing of the periventricular white matter. There is involvement of the basal ganglia bilaterally with sparing of the internal capsule, involvement of the dentate nuclei while sparing the cerebellar white matter. Glutaric aciduria type 1. Most children present with an acute metabolic crisis. There is macrocephaly with mild ventriculomegaly and characteristic widening of the Sylvian fissure with dilatation of subarachnoid spaces, and may complicate by subdural hematomas or hygromas without significant history of trauma. During an acute metabolic crisis, there is cytotoxic edema in the corpus striatum. Later, there is atrophy of the corpus striatum. Shifting to lysosomal disorders or mucopolysaccharidosis. 7 types of mucopolysaccharidosis are described. Hurrell and Morquio syndrome are the most well-known. There is diffuse ventriculomegaly with non-specific white matter periventricular hyperintensities and characteristic dilatation of the perivascular spaces, while the spine showed spinal canal stenosis and spinal cord decompression with rosette myelopathy. GM gangliosidosis, it may be due to Tay-Sachs disease or Zandorf disease. There is hyperdense salami, while MR T2 hypointense and T1 hyperintense salami, And there is for retina, there is cherry red spot in the retina. Krabbe disease due to accumulation of galactocerebrosid within the macrophages or globoid cells. There is hyperdense thalami and T2 hypointense thalami. Involvement of the white matter, central white matter involvement sparing the subcortical fibers, and characteristic peridentate hyperintensities. Also, there is thickening of the optic chiasm, enhancement of the cranial nerve and coda equina root. Menkes disease or kinky hair, kinky vessel syndrome. These characteristics are tortuosity of the intracranial vessels, which may complicate by bilateral subdural hematomas. Shifting to the developmental megalencephaly. It is due to dysfunction of the BI3K ACT-mTOR signaling pathway, divided into neurocutaneous syndrome or overgrowth syndrome. Neurocutaneous syndrome, the NF1 tuberous sclerosis Gordon syndrome. Overgrowth syndrome with or without vascular malformation. NF1 is macrocephaly observed in about 35 to 45%, leading to diffuse megalencephaly with thick corpus callosum. Other stigmata of NF1, such as bilateral basal ganglia and thalamic UBOs and optic nerve glioma. Tuberous sclerosis complex macrocephaly may be due to either hemimegalencephaly or obstructing hydrocephalus from enlarging subependymal giant cell astrocytoma. Gordon syndrome, characterized by palmar beat, bifid ribs, and dural calcification. There is a predisposition to odontogenic keratocyst and medulloblastoma, such as in the case left cerebellar desmoplastic medulloblastoma, which belongs to Sonic hedgehog molecular subgroup. Second is megalencephaly with overgrowth syndrome. It is divided into overgrowth syndrome with vascular malformation, BIC3ACA related overgrowth syndrome or broad spectrum, or overgrowth syndrome without vascular malformation. Broad spectrum include Klebel-Treonase syndrome, Clovis syndrome, megalencephaly, capillary malformation, while without vascular malformation include Proteus, Sutis, Bickus-Widman, and other syndromes. Broad spectrum is an umbrella term that refers to large spectrum of condition characterized by vascular malformation with tissue overgrowth and with megalencephaly. Due to common genetic mutation in BIC3ACA gene, leading to activation of BI3K ACT-mTOR pathway. This pathway is important for cellular growth, angiogenesis, mutation in this pathway leading to vascular anomalies and limb overgrowth, and hemimegalencephaly. We'll focus upon the BIC3CA mutation, ACT mutation, and PTEN mutation. Klebel-Treonase syndrome, this is a triad of port wine stain, low flow vascular malformation, bone and soft tissue hypertrophy of the affected limb, the characteristic lateral marginal vein of cervical, which in enlarged lower limb extremity is often pathognomonic of KTS, with absence of high flow vascular malformation compared to Parkes-Weber syndrome. MR showed the right hemimegalencephaly, right ventricular with right cerebellar enlargement, and frontal polymicrogyra. Clovis syndrome is acronym for congenital lipomatous overgrowth of the trunk, vascular malformation, epidermal nevi, scoliosis, skeletal, and spinal malformation. MR neuroimaging shows left side hemimegalencephaly with malformation of cortical development, cerebellar dysplasias, lipomatous malformation over the left side of the face, scalp, and neck. Megalencephaly, capillary malformation characterized by capillary malformation of the philtrum, macrocephaly with developmental delay, and skin laxity of the forehead, syndactyly of the third and second toes. MR showed bilateral hemimegalencephaly with malventriculomegaly, characteristic perisylvian microgyra, tonsillar herniation, cerebellar dysplasias, and bilateral lipomatous overgrowth over the face. عشان ما نتوهش بس نرجع تاني للكلاسيفيكيشن بتاعنا اللي هو ديفلوبمنتال ميجالينسيفالي اللي هو نيوروكوتينيوس سندروم اوفرجروث سندروم. احنا خلصنا النيوروكوتينيوس وخلصنا الفاسكولار بروس سبيكترم، اتبقى لنا without vascular malformation بروتيس سندروم اللي هم this is a prototype of overgrowth syndrome due to somatic mutation in ACT1 gene. The presence of cerebriform connective tissue nevi is near pathognomonic. Skeletal chains are the most frequently expressed manifestation. Proteus syndrome, the lateral X-ray showed dolichocephaly with increased anteroposterior diameter of the skull, periventricular cystic change, polymicrogyra, focal calvaria thickening, and soft tissue hypertrophy of the right side of the face. Another case of Proteus syndrome with right-sided hemimegalencephaly, right cerebellar enlargement, soft tissue overgrowth over the right side of the face. Sutis syndrome, characterized by distinctive facial feature. Neuroimaging typically showed no malformation of cortical development. Imaging shows megalencephaly, mild ventricular enlargement, persistent septum pellucidum, subcortical signal abnormalities, corpus callosum hyperplasia more severe posteriorly. Beak-with-Whitman syndrome is characteristic feature characterized by neonatal microglossia. It has predisposition to embryonal tumors such as Wilms tumor and hepatoblastoma, and they may be associated with posterior fossa abnormalities such as plaque pouch cyst, inferior vermin hypoplasia, and the Walker malformation. Fourth is PTEN hamartoma tumor syndrome. PTEN is a tumor suppressor gene. It acts as down-regulator of PI3K ACT-mTOR pathway. This is an umbrella term including several clinical syndrome related to mutation in PTEN gene, leading to multi-system hamartomas and malignancies. Cowden syndrome is the most common phenotype of PTEN hamartoma tumor syndrome. There is increased risk of breast, thyroid, colon, kidney, and endometrial carcinoma. Imaging showed macrocephaly with Lermet-de-Clos disease or cerebellar dysplastic gangliocytoma. The last one is megalencephaly, polymicrogyra, polydactyly, hydrocephalus, due to mutation in ACT3 gene. Imaging showed left-sided hemimegalencephaly, right-sided polymicrogyra, thickening of the corpus callosum and fornix. Lastly, the fourth compartment of the skull, macrocephaly may be due to skeletal dysplasias such as achondroplasia or thalassemia with extramedullary hematopoiesis. Lastly, the roadmap to evaluate a child with macrocephaly, starting with thorough clinical examination. Then the first step is to exclude raised intracranial pressure, which may be due to hydrocephalus or obstructing tumor. If not, the second step, search for syndromic features, which may be due to overgrowth syndrome with or without vascular malformation, or cutaneous lesion or neurocutaneous syndrome. If not, searching for neurodevelopmental delay or regression, which may be due to metabolic disorders such as leukoencephalopathy, leukodystrophies, organic acidurias, lysosomal disorder, or Menkes disease. And lastly, if not, the diagnosis of exclusion is familial macrocephaly or benign enlargement of subarachnoid spaces. Thank you.